This lecture is on Chapter 7, the Integumentary System. Our chapter objectives are to describe the primary pathology in the integumentary system, describe integumentary system manifestations of other systemic pathologies, discuss thermal injuries, including classification of burns, discuss signs and symptoms of skin ulceration, including vascular, neuropathic, and pressure-related ulcers, and to discuss integumentary red flags such as signs and symptoms of skin cancer, cellulitis, and spread of infection to lymph system. In discussing the integumentary system, it's important to remember that the skin is the largest organ in the body and accounts for about 15 to 20% of our body weight. Approximately 1 in every 4 people who consult a physician has a skin disorder. Skin lesions can occur as a result of a wide variety of etiological factors. Lesions of the skin or skin manifestations of systemic disorders can be classified as a primary or secondary lesion. The primary lesion is the first lesion to appear on the skin and has a visually recognizable structure that can be a papule, nodule, a tumor, a vesicle, or something along those lines. When changes occur in the primary lesion, it becomes a secondary lesion. Examples can be scaling, thickening, crust, ulcer, a scar. These changes may result from many factors, including scratching, rubbing, medication, natural disease progression, or the processes of healing. Some of the signs and symptoms of integumentary disorders include pruritus, which is itching. It is one of the most common manifestations of dermatological disease and is a symptom of underlying systemic disease in up to 50% of people with generalized itching, especially among the chronically ill and older populations. It can lead to damage if scratching injures the skin's protective barrier, possibly resulting in increased inflammation, infection, and scarring. Many systemic disorders can cause pruritus, most commonly diabetes mellitus, drug hypersensitivity, and hyperthyroidism. Urticaria, also known as hives, is a vascular reaction of the skin marked by the appearance of smooth, slightly elevated patches. These are redder or paler than the surrounding skin and are often accompanied by severe itching. A rash is a mild form of hives. I think we're all familiar with what a rash is. Blisters can also be called vesicles, are fluid-containing elevated lesions of the skin with clear, watery, or bloody contents. They can occur as a manifestation of a wide variety of diseases. Blisters may be primarily associated with diseases of a genetic or autoimmune origin, or may be secondary to viral or bacterial infections of the skin. Examples are herpes simplex or impetigo, local injury to the skin, such as burns, ischemia, pressure, or dermatitis, or drug administration. Xeroderma is a mild form of itchy skin or excessive dryness of the skin characterized by dry, rough, discolored skin with the formation of scaly, shedding sheets of epithelium. This problem is accentuated by dry climates and the use of drying cleansers, soaps, disinfectants, and solvents. Mongolian spots are congenital dermal melanocytosis. Mongolian spots are common among people of Asian, East Indian, Native American, Alaskan American, African, and Latino or Hispanic heritage. They are also present in about 1 in 10 fair-skinned infants. Bluish gray to deep brown to black skin markings often appear at the base of the spine, on the buttocks and back, and even sometimes on the shoulders, ankles, or wrists. Mongolian spots may cover a large area of the back. When the melanocytes are close to the surface, they look deep brown. The deeper they are in the skin, the more bluish they look, often mistaken for signs of child abuse. These spots generally fade with age as the child grows and usually disappear by the age of 5. The skin undergoes numerous changes that can be seen and felt throughout the lifespan. The most obvious changes occur first during puberty and again during older adulthood. Hormone changes during puberty stimulate the maturation of hair follicles, sebaceous glands, and apocrine or estrogen units in certain body areas. Mild acne, perspiration, and body odor, freckles promoted by sun damage or sun exposure, I should say, and pigmented nevi, which are moles, are common occurrences. During adolescence and adulthood, the use of birth control pills or pregnancy may result in temporary changes in hair growth patterns or hyperpigmentation of the cheeks and forehead, known as melasma or pregnancy mask. Other hormonal abnormalities may result in excessive facial and body hair in women. Hormonal and genetic changes also produce male pattern baldness, also known as alopecia, which could be in men or women. At least the term alopecia just means hair loss. Smoking is an independent causative factor of facial wrinkles. The skin exhibits changes that denote the onset of senescence, which is the process or condition of growing old. These changes may be caused by the aging process itself, the cumulative effects of exposure to sunlight, or environmental factors. As aging occurs, both structural and functional changes occur in the skin, resulting clinically in diminished pain perception, increased vulnerability to injury, decreased vascularity, and weakened inflammatory response. Visible indications of skin changes associated with aging include gray hair, balding, and loss of secondary sexual hair, and increased facial hair. For women, excessive facial hair may occur along the upper lip and around the chin. Women may also experience balding after menopause. Men frequently develop increased facial hair in the nose, also known as nares, eyebrows, and in the ear. Other common age-related integumentary changes include lax skin, vascular changes, such as decreased elasticity of blood vessel walls, dermal or epidermal degenerative changes, and wrinkling. Wrinkling signifies loss of elastic fibers, weakened collagen, and decreased subcutaneous fat, and is accelerated by smoking and excessive sun exposure. Atopic dermatitis is a form of allergy in which hypersensitivity reactions such as dermatitis or asthma may occur in a part of the body not in contact with an allergen. Atopic dermatitis is a chronic inflammatory skin disease. It is the most common type of eczema, frequently already present during the first year of life and affecting more than 10% of children. The exact cause of atopic dermatitis is unknown, although recent studies have demonstrated the complex interrelationship of genetic, physical, environmental, skin barrier, pharmacological, psychological, and immunologic, etiologic factors that contribute to the development and severity of atopic dermatitis. The pathomechanism associated with atopic dermatitis are also unknown, but most likely include both immediate and cellular immune response. Compared with normal skin, the dry skin of atopic dermatitis has a reduced water binding capacity, higher transdermal water loss, and a decreased water content. Rubbing and scratching the itchy skin are responsible for many of the clinical changes seen in the skin. Hands frequently in and out of water make the condition worse. Atopic dermatitis begins in many people during infancy in the form of a red, oozing, crusting rash classified as acute dermatitis. As the child grows, the chronic form of dermatitis results in skin that is dry, thickened, and brownish gray in color. The rash tends to become localized to the large folds of the extremities as the person becomes older. It is found mainly in flexor surfaces such as the elbows and knees, neck, sides of the face, eyelids, and back of the hands and feet. Hand and foot dermatitis can become a significant problem for some people. There is no cure currently for atopic dermatitis. However, it does often resolve spontaneously, and more than 90% of cases can be effectively controlled through proper management. The goal of medical therapy is to break the inflammatory cycle that causes excessive dryness, cracking, itching, and scratching. Contact dermatitis can be an acute or chronic skin inflammation caused by exposure to a chemical, mechanical, physical, or biological event. This is one of the most common environmental skin diseases occurring at any age. As people age, they may develop delayed cell-mediated hypersensitivity to a variety of substances that come in contact with the skin. Common sensitizers include nickel, which is found in jewelry, and some foods, chromates used in tanning leathers, wool fats, particularly lanolin, which is found in moisturizers and skin creams, rubber additives, topical antibiotics, and topical anesthetics such as lidocaine. There's also a small percentage of the population that is allergic to silicone, which again, similar to like we talked about with TheraBand, you always want to ask your patient if they have any allergies to topical agents or any type of equipment prior to using it with your patient. Contact dermatitis appears as an intense itching, redness, and edema of the skin that occurs 1 to 2 days after its exposure, in previously sensitized persons. Clinical manifestations begin at the site of exposure, but then it can extend to more distal sites. These conditions may progress to where there's actually oozing, crusting, and scaling occurring. If the symptoms persist and the skin becomes thickened with prominent skin markings and pigment changes. If you are suspected to have contact dermatitis, you should be referred to a physician. They would take a detailed history and physical or examination, which is used in helping to diagnose. It may be necessary to perform patch testing to identify what's causing the dermatitis. The primary treatment is the removal of anything that is causing the irritation in the skin. Acute lesions usually resolve in 3 weeks. However, chronic lesions persist until that causative agent has been removed. So in this image, for example, appears to be from a ring. So once that piece of jewelry has been removed, within a couple weeks, that dermatitis should resolve. Eczema and dermatitis are terms that are often used interchangeably to describe a group of disorders with a characteristic appearance. Eczema and dermatitis is a superficial inflammation of the skin caused by an irritant, exposure, allergic sensitization, or genetically determined idiopathic factors. Many types of dermatitis are represented according to these major etiological categories. There's allergic dermatitis, irritant dermatitis, um, atopic dermatitis. So all of those are forms of eczema / dermatitis. There are 3 types or primary stages: acute, subacute, and chronic. Dermatitis is a common skin disorder in older people. It may be caused by hypoproteinemia, meaning low amounts of protein, venous insufficiency, allergens, irritants, or some sort of underlying malignancy, such as either leukemia or lymphoma. Since older people often take multiple medications, dermatitis from drug-drug interactions can occur. Rosacea is a chronic facial disorder of middle-aged and older people. Although it is a form of acne, it is differentiated by age, the presence of large vascular components, and usually the absence of comedones. Clinically, the cheeks, nose, and chin, however, sometimes the entire face, have a rosy appearance that appears as reddened skin. This is a benign condition, however, it is an obvious condition and is most common in people with fair skin or people who get flush really easily or their face turns red. Sun, hot weather, and humidity can trigger flare-ups. So this condition is often worse in the summer. Medical management is aimed at the inflammatory papules, pustules, and surrounding redness and swelling that include topical or systemic therapy. Rosacea tends to be a persistent condition that can be controlled with medications or drugs. Chronic rosacea has long been treated by pulse dye laser. Skin infections, we covered most of these in infectious disease. However, just to break them down, bacterial, viral, fungal, and parasitic. Many bacterial, viral, fungal, and other parasitic skin infections encountered by the PTA are not the primary focus of intervention, but rather can occur in clients who are hospitalized or being treated for some other condition. Many of these skin disorders are contagious and require careful handling by healthcare professionals to avoid the spreading of the infection and becoming contaminated. So bacterial type of infections, skin infections can be impetigo, cellulitis. Viral infections can be herpes zoster, warts. Fungal can be ringworm. However, ringworm is not a worm, it is a fungus. And then there's athlete's foot. Parasitic infections include scabies or pediculosis, which is lice. Impetigo is a superficial infection commonly caused by staphylococci or streptococci. It is most commonly found in infants, young children 2 to 5 years of age, and older people. Some of the predisposing factors include close contact in schools, overcrowded living quarters, poor skin hygiene, anemia, malnutrition, and minor skin trauma. It can be spread by direct contact or environmental contamination. It appears as small macules, which are flat spots that rapidly develop into vesicles or small blisters, and then can develop into pus-filled blisters. When the vesicles break, a thick yellow crust forms. The exudate, causing pain, surrounding redness and inflammation. There can also be some cellulitis in the surrounding tissues and itching. Single small lesions can often be managed by soaking them for 10 minutes with drying agents. Oral antibiotics are regularly used to treat impetigo. Cellulitis is a rapidly spreading acute inflammation with infection of the skin and subcutaneous tissue that spreads widely through the tissue spaces. Clients or patients, I like to use the word patients, at increased risk for cellulitis include older adults and people with lower resistance from diabetes, malnutrition, steroid therapy, and the presence of wounds or ulcers. Other predisposing factors include the presence of edema or other cutaneous inflammation or wounds. Examples can be eczema, burns, trauma, venous insufficiency or stasis, thrombophlebitis, surgery or substance abuse, immunocompromise, and lymphedema also predispose individuals to this condition. There is a tendency for reoccurrence, especially at sites of lymphatic obstruction. A surface of the skin in individuals with cellulitis affects the upper dermis and is characterized by patches of skin that are red and painful with sharply defined borders and that are hot to the touch. Red streaks extending from the patch indicate that lymph vessels have been infected. Facial cellulitis involves the face, especially the cheek or around the eyes, and the neck can also be affected. Intravenous or IV antibiotic infusion is the primary treatment. Oral antibiotics can be effective if the infection is caught early. Individuals who are susceptible to recurrent cellulitis may have a prescription for oral antibiotics on hand, or at least a prescription that can be filled at first signs of infection. Again, cellulitis is one of those conditions that medical personnel may draw a line around the reddened area to see if it either spreads or if it actually is decreasing. Now we're going to discuss viral skin infections. Viruses are intracellular parasites that produce their effect by using the intracellular substances of host cells. In a viral infection, the epidermal cells react with inflammation and vesiculation or proliferating to form growths. Herpes zoster or shingles is a local disease brought about by the reactivation of varicella zoster virus, the same virus that causes systemic diseases called varicella, which is also known as chickenpox. The initial infection of varicella zoster virus is common during childhood. Shingles may occur and reoccur at any age, although peak incidence occurs from ages 50 to 70. An estimated 300,000 episodes of zoster occur annually. Of these episodes, 95% are first occurrences and 5% are reoccurrences. The vesicular eruption of zoster generally occurs unilaterally in the distribution of a specific dermatome supplied by a dorsal root or extramedullary cranial nerve sensory ganglion. Most often this involves the trunk or the area of the fifth cranial nerve. 2 to 4 days before eruption, the affected person may have some warning signs that the virus has become reactivated, especially in repeat incidences. Early symptoms of pain and tingling along the affected spinal or cranial nerve dermatome are usually accompanied by fever, chills, malaise, and gastrointestinal disturbances. 1 to 3 days later, red papules are seen along the dermatome. Occasionally, herpes zoster involves the cranial nerves, especially the trigeminal and geniculate ganglion of the oculomotor nerve. In rare cases, herpes zoster leads to generalized central nervous system infection, muscle atrophy, motor paralysis, usually transient, acute transverse myelitis, and ascending myelitis. More often, generalized infection causes acute retention of urine and unilateral paralysis of the diaphragm. Diagnosis is usually based on clinical examination and the recognition of the skin lesions with accompanying systemic signs of infection. Laboratory diagnosis may include culture and histologic examination of the skin biopsy specimen. There is no curative agent for shingles, but supportive treatment to relieve itching and neuralgic pain is provided. The use of systemic corticosteroids within the first week of eruption may abort the attack and appear to reduce both acute symptoms and the risk of post-eruption neuralgia in older people. A live varicella virus vaccine is available for use in persons 12 months of age or older who have not had varicella. Overall, the prognosis is good unless the infection spreads to the brain, which is very rare. Other viral skin infections include warts. Warts are common benign viral infections of the skin and adjacent mucous membranes caused by HPV or the human papillomavirus. The incidence of warts is highest in children and young adults, but warts can occur at any age. Transmission is probably through direct contact, but auto-inoculation is possible. Warts may appear singly or as multiple lesions with thick white surfaces containing many pointed projections. The clinical manifestations depends on the type of wart and its location. The most common wart is referred to as Verrucae vulgaris and appears rough, elevated, round surface, most frequently on the extremities, especially the hands and fingers. There's also plantar warts, which are slightly elevated or flat, occurring singly or in large clusters, and are primarily at the pressure points of the feet. Diagnosis is usually made on the basis of visual examination. Treatment of warts. Some warts respond to simple treatment and some disappear spontaneously. Warts can be chronic or recurrent. There are many different types of treatments available. Some of them include over-the-counter treatments, cryotherapy, acid in a liquid form. So there are various different ways of treating it, including actually removal of the wart itself. Fungal skin infections, such as ringworm, are caused by a group of fungi that invade the stratum corneum, hair, and nails. These superficial infections by fungi that live on, not in, the skin and are confined to the dead keratin layers, unable to survive in the deeper areas. Fungal infections will spread without treatment. Antifungal creams are available over the counter, but it is important to have it diagnosed first. Ringworm is a type of fungal infection of hair, skin, or nails. It has no association with worms, but rather is the formation of ring-shaped pigmented patches covered with vesicles or scales that often become itchy. Transmission can occur directly through contact with infected lesions or indirectly through contact with contaminated objects such as shoes, towels, shower stalls, things like that. Athlete's foot can cause redness, skin peeling, itching between the toes that may spread from the interdigital spaces to the sole. So it can begin between the toes and then move to the soles of the feet. Severe infection can result in inflammation with severe itching and pain with walking. Some individuals develop a strong foot odor as well. Athlete's foot can often be observed by PTAs. It is important that if you do recognize some of these signs and symptoms that you encourage the person to seek treatment. Scabies are actually mites. They are highly contagious and again are caused by a mite that gets within the skin. It's a common public health problem with an estimated prevalence of 300 million cases worldwide. The female mite burrows into the skin and deposits eggs that hatch into larvae in a few days. Scabies is easily transmitted by skin-to-skin contact or by contact with contaminated objects, such as linens or shared objects. The symptoms include intense itching, which is worse at night, which then leads to excoriated skin, and the burrow, which is usually a linear ridge with a vesicle at one end. The mite is usually found in the burrow, commonly in the interdigital web space, the flexor aspect of the wrist, armpit, waistline, nipples in females, genitalia in males, and the umbilicus. The mite can be removed with a scalpel and be tested or examined under a microscope. That could be one way it's diagnosed. However, in longer standing cases, they may not find a mite. If they're unable to find the mite, it can still be presumed that scabies is the diagnosis. Treatment has been with scabicide, usually a lotion or a cream that's applied to the entire body from the neck down. There's also a single oral dose therapy, which is effective treatment for an infestation. Pediculosis is lice, which I think a lot of you are familiar with. So skin cancer, to begin, we're going to talk about benign tumors. Seborrheic keratinosis is a hereditary benign proliferation of basal cells occurring most frequently after middle age and manifesting as multiple lesions on the chest, back, and face. The lesions often appear after hormonal therapy or inflammatory dermatosis. These areas are waxy, smooth, or raised lesions that vary in color from yellow to beige to dark brown or black. Nevi are pigmented or non-pigmented lesions that form from aggregations of melanocytes beginning early in life. Most moles are pale brown, black, or flesh-colored and may appear to have many parts of the skin, may appear on many parts of the skin. They vary in size and thickness, occurring in groups or singly. Some precancerous conditions, there is actinic keratosis, is a skin disease resulting from many years of exposure to sun UV rays. The damage caused by overexposure to sunlight results in abnormal cell growth, causing a well-defined, crusty, or sandpaper-like patch or bump that appears on chronically sun-exposed areas of the body. Bowen's disease can occur anywhere on the skin or mucous membranes. It causes a persistent brown to reddish brown, scaly plaque with well-defined margins. Often the person has a history of arsenic exposure in youth. Basal cell carcinoma is a slow-growing surface epithelial skin tumor originating from undifferentiated basal cells contained in the epidermis. This type of carcinoma rarely metastasizes beyond the skin and does not invade blood or lymph vessels, but can cause significant local destruction. Squamous cell carcinoma is the second most common skin cancer in Caucasians, usually arising in sun-damaged skin, such as on the rim of the ear, the face, the lips, and mouth. It is a tumor of the epidermal keratinocytes and rarely occurs in dark-skinned people. Malignant melanoma is a neoplasm of the skin originating from melanocytes or cells that synthesize the pigment melanin. Melanomas occur most frequently in the skin, but can also be found in the oral cavity, esophagus, anal canal, vagina, or meninges, or within the eye. Kaposi sarcoma is a malignancy of vascular tissue that manifests as a skin disorder. In the past, this tumor was most commonly seen in older men of Mediterranean or Eastern European origin, especially men of Jewish or Italian ancestry. The sudden emergence of this malignancy in the Western world is directly related to AIDS-associated immunodeficiency, and the incidence has risen dramatically along with the incidence of AIDS. It may also occur in kidney transplant recipients taking immunosuppressive drugs. Some other skin disorders which we discussed in autoimmune disorders are psoriasis, lupus, systemic sclerosis, and dermatomyositis. The images here you can see on the far right, there's deforming arthritis of the hands in a person with psoriasis. The middle picture is the lesions that are typical for systemic lupus. They are ulcerated, punched out wounds with necrotic bases. And the picture on the far left is the butterfly rash that is can be present in individuals with systemic lupus as well. So here you can see some thermal injuries. First we have burns. So injuries that result from direct contact or exposure to any thermal, chemical, or electrical or radiation source are termed burns. You can see a burn in the top image there. Burn injuries occur when energy from the heat source is transferred to the tissue of the body. The depth of the injury is a function of the temperature or source of energy and duration of exposure. The severity of a burn is assessed with respect to the risk of infection, mortality, and cosmetic or functional disability. The bottom image that you can see there is from a cold injury. So that is an image of frostbite. Cold injuries result from overexposure to cold air or water and occur in two major forms, either localized injury, which is frostbite, or systemic injuries, which is considered hypothermia. Untreated or improperly treated frostbite can lead to gangrene and may eventually lead to amputation, requiring therapy and rehabilitation. Hypothermia is a medical emergency and is not discussed in detail right here, but we will possibly discuss it later on. Again, cold-induced injuries can either be local or systemic. Severe cold affects all organs and systems, and especially the central nervous system and cardiovascular system. Here's kind of a breakdown of the different layers of skin from the epidermis, dermis, and subcutaneous tissue. And you can see what the cause of those burns are. So for example, in the epidermis, that would be your typical sunburn. It can be mild to severe, redness, dryness, blisters, edema. It can be painful. There can be tingling. The discomfort usually lasts for about 48 hours. Within the dermis, you now have a partial thickness burn or a second degree burn. So in the epidermis, that was a superficial burn or first degree burn. If it goes into the dermis, it is now a partial thickness or second degree burn. It is superficial, usually from scalding liquids, semi-liquids such as oil or tar, or from solids. Or can be deeper from an immersion scald or a flame. These are definitely a lot more painful. Superficial partial thickness burns heal within 14 to 21 days. Deep partial thickness burns require 21 to 28 days for healing. The healing rate varies with burn depth and the presence or absence of infection. A full thickness burn has now gone into the subcutaneous tissue, and this is from more prolonged exposure to either chemical, electrical, flame, or scalding liquids or steam. Full thickness, dead skin, usually take, let's see, spontaneous healing may be imposed, but small areas may be left alone to form scarring without grafting. This may require removal of eschar, which is that dead skin, and also may lead to skin grafting. This is an image of the rule of nines. This is important to understand. It's important to understand if a full arm was burnt, what percentage would that be? The PTA may be involved in wound care for minor burns, consisting of cleansing, removal of damaged agents, debridement of loose, non-viable tissue, and application of different creams or ointments. Blister management is usually included in the debridement of a blister. Treatment of major burns includes life-saving measures. So the ABCs, which are airway, breathing, and circulation, immediately after the injury, followed by restorative care, which includes infection control, wound care, skin grafting, pain management. We're highly involved in that phase or in that with major burns, specifically with wound management, positioning, functional mobility, things like that. So also in helping to prevent contractures from scarring. Here you can see a pediatric scald burn. The image on the left is the corresponding Lund-Browder, how they rate the percentage of burns for a pediatric patient. Other integumentary disorders include pigmentary disorders, blistering disease, and cutaneous sarcoidosis. I'm not going to go into detail on these, but there is more information that you can look at in your book. Lastly, we're going to talk about pressure ulcers. So pressure ulcers are staged, and they're staged by the thickness of the ulcer. Integumentary ulcers can be caused by a variety of underlying disorders, including diabetes, arterial insufficiency, radiation damage, vasculitis, and prolonged pressure. A pressure ulcer used to be called a bed sore, or formerly called bed sores or decubitus ulcer, is a lesion caused by unrelieved pressure resulting in damage to the underlying tissue. Pressure ulcers usually occur over the bony prominences such as heels, sacrum, ischial tuberosities, greater trochanters, elbows, scapula, and are staged to classify the degree of tissue damage. A stage 1 pressure injury is non-blanchable arrhythmia in intact skin. Intact skin with localized area of non-blanchable arrhythmia, which may appear differently in darker pigmented skin. There can be changes in sensation, temperature, and the firmness of the skin. Stage 2 pressure injury is a partial thickness skin loss with exposed dermis. Partial thickness loss of skin with exposed dermis. The wound bed is viable, pink and red, moist, and may be present as an intact or ruptured serum-filled blister. Adipose or fat tissue is not visible, and deeper tissues are not visible. These injuries commonly result from adverse microclimate and shear in the skin over the pelvis and shear at the heels. A stage 3 pressure injury is a full thickness skin loss. Full thickness skin loss of skin in which adipose or fat is visible in the ulcer and granulation tissue and epibole, which is rolled wound edges, are often present. Slough and or eschar may be visible. The depth of tissue damage varies by anatomical location. Areas of significant adipose can develop deep wounds. Undermining and tunneling may occur, which is exactly what that means. There can be tunneling of deeper tissues. Fascia, muscle, tendon, ligament, cartilage, and or bone are not exposed. A stage 4 pressure injury is a full thickness skin and tissue loss. Full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough and or eschar may be visible. You may see the rolled edges again. Undermining and or tunneling often occur. The depth would vary here by anatomical location, meaning how close the bony prominences are to the surface. Unstageable pressure injury, obscured full thickness skin and tissue loss, in which the extent of tissue damage within the ulcer cannot be confirmed because it is obscured by slough or eschar. So in these cases, if you're unable to identify how deep that pressure injury is. Stage 3 or stage 4 pressure injury will be revealed. Stable eschar, example dry, adhered, intact without redness or fluctuance on the ischemic limb or the heel, should not be removed. Deep tissue pressure injury is a persistent, non-blanchable, deep red, maroon, or purple discoloration. Intact or non-intact skin with localized area of persistent, non-blanchable, deep red, maroon, purple discoloration, or epidermal separation, revealing a dark wound bed or blood-filled blister. Pain and temperature change often precedes skin color changes. Discoloration may appear differently in darkly pigmented skin. This injury results from intense and/or prolonged pressure and shear forces at the bone-muscle interface. Here you can see some guidelines for prevention of pressure ulcers, regular skin inspections, cleaning soiled skin. You never want a person with an area of skin that is soiled or wet for any long periods of time. Minimize dry skin and injury to skin. So you want to keep the skin moisturized, however, you don't want it wet or soiled. Maintain mobility. So the more mobile a person is, the less likely they are to get pressure injuries. Reposition and avoid dragging. So in this image here, you can see a person lying in a semi-side lying position with pillows and wedges protecting the bony prominences. So with that, the lecture for integumentary is complete.